The next speaker is Dr. Anthony Aldave. He'll be talking on DMEK in glaucomatous eyes and deep anterior chamber.
Thank you very much for the invitation to speak, and given the time that was given, I decided to focus on DMEK in eyes with deep anterior chambers. Great to see standing room only here. How many people in this room do DMEK surgery? Okay, good. So this will be relevant for you guys. For those who don't start with deep anterior chambers. Start with simpler eyes. None of my disclosures are relevant to this presentation. So we're going to talk about a couple of techniques for endo in DMEK and then endo out. So here's a patient of mine, prior trab, pressure of 3 post-op, deep anterior chamber, post-vitrectomy, and as you see, this graph's a little bit big for this eye. So I usually use a tapping technique to unfold, but I'm not getting anywhere in this case because I just cannot shallow this chamber. It does not respond. All of us that do a lot of DMEK know how the graph should respond, and when it's not responding, there's a reason. Vitreous, deep anterior chamber, fibrin, something. But here I'm just struggling to try to get one portion of this graph to unfold to my left, which is my preferred technique, and then unfold to my right. Even when I'm just trying to move the graft over, it's not moving. So in a case like this, you have to avoid just sort of repetitive tapping that's non-purposeful. That's why I tell the fellows, every movement should have a purpose. Stopping, shallowing the chamber again. Here you see drawing some fluid out. In this case, it's just not unfolding. So what I recommend in these eyes, take advantage of the depth of the chamber and use this direct manipulation technique with your cannulas. Here we're touching the stromal side of Decimase to unfold that leaf. Much easier than trying to tap it out. In a chamber that's deep, it will not shallow on you during this maneuver. Once you get that portion unfolded, then it's like a routine case. I like this compress and release technique. It's a slow downward movement and then a rapid upward movement to create a vacuum that pulls this graft open. You'll see me use it again here. So it's a quicker upward stroke, creates a vacuum and pulls that graft open. Once you have it open, then you can get your air bubble beneath it. In a deep anterior chamber, you may never get the graft to completely unfold. You may still have one edge that's still folded. You'll see in the next video, don't worry about that. Get the air bubble beneath it and you can then tap out that edge. Here's another endo out case. This case, no trab, but deep anterior chamber. Post-vitrectomy, high myope. And again, I am struggling to get this out of a tubular configuration and try to make it flat. Doing everything I can, I'm tapping on it. I've removed as much aqueous as I can. I'm going to go in, and in this case, I'm not just burping fluid, I'm actually aspirating fluid out of the anterior chamber. When you do that, then you can see that whole cornea sinks. Now we have a concave cornea. You'll get that sort of annular light reflex off the concave cornea. If you're not getting anywhere, stop. 1 cc syringe with 0.1 cc of air. Go beneath the iris. Go out as far as you can towards the iris root and inject a very small air bubble. If you're peripheral enough, it won't go through the pupil, just bring the iris plane up towards you. In this case, I'm doing it along where the graft is positioned. Now I've got the iris is up. I'm actually able to get this cornea in more of a flatter configuration that's going to allow me to begin to unfold this graft. A finger on the globe can also be very helpful to bring that iris plane up on these eyes that have very deep anterior chambers. And when you release that finger, the cornea will become concave again. It will sort of lock in a graft. You've been able to unfold it. One other technique I like to use, I call it the vampire technique or aspiration technique, which again is coming in with a 30 gauge cannula. This time you're touching the endothelial side, but a very small area. You're going to aspirate and pull that graft over. You cannot do this in a normal eye, but you can do it in these very deep chambers. So another technique to really help you try to get one side unfolded, then allow you to unfold the other using whatever technique you like. You can see here doing it again. It's actually quite easy as long as the edge of the graft is curled up. If it's flat, you can't do this. But if it's curled up, as it usually is in a deep anterior chamber, it's a very nice technique to pull the graft over and then allow you to begin to unfold it. Now I've got this side unfolded. I'm going to do the same technique you saw in the prior video with that cannula, the direct manipulation technique. Going to push this other side unfold. So in this case, I've unfolded the graft without the normal tapping technique. One side I aspirated, the other side I pushed with the cannula, and lo and behold, got this graft unfolded. Now you see where the S is, we still have an edge fold. There's no way of getting this graft completely unfolded. But as long as you get air beneath it to pick it up, as long as you don't have air underneath the folded edge, you can then tap it out. So you just tap at the limbus, and this edge should unfold. If it's not unfolding for you, it's probably because you have air beneath what's folded. You need to reduce the size of your air bubble. Once that's unfolded, then we're in good shape. We're going to fill the anterior chamber. And these are challenging eyes. If you know you have a deep anterior chamber, one of the things you can do to make your life easier is make sure you request older tissue from the eye bank. U.S. eye banks are now recovering from patients up to age 80. And so you ask for a tissue of somebody in their 70s when you know you have a deep anterior chamber, so you're not struggling with both a tight scroll and a deep anterior chamber, which is a deadly combination. So in cases of endothelium out techniques to shallow the anterior chamber, releasing fluid, we're all familiar with that, placing air beneath the iris. People say, well, don't you have to get that air out? Yes, you would ideally, when you're going to be taking the air out at the end of the case, push on the iris and try to burp it through. But a very small amount of air behind the iris is usually not an issue. Digital pressure on the globe during the unfolding maneuver, and then releasing it to prevent scrolling of the graft once it's unfolded. Techniques to unfold and center the DMEK graft. That compress and release, the slow downward, rapid upward is one of my preferred techniques for unfolding. Direct manipulation of the graft using 1 or 2 cannulas. Some people will put in 2 cannulas and then move them apart to unfold the graft. Aspiration technique, or the vampire technique, and I didn't show you this injection of air bubble above or below the graft. If you're really struggling to unfold it, you can just put an air bubble above it, flatten it like a pancake on the iris, and then go below it and bring it up with an air bubble. Now, endo-in is another technique. In this case, the graft's going to be folded either by the surgeon endo-in or by the eye bank. And this is really helpful for these deep anterior chambers. This takes the depth of the anterior chamber out of the equation. So this is an animated video from CorneaGen. I have no financial interest, but I do consult for CorneaGen. What this technique uses are these irrigating forceps. So it's your forceps very similar to what you would use for DSAC surgery, microforceps, but with this irrigating sleeve that's coaxial. So while you're holding the graft inside the eye, the coaxial fluid flow helps to unfold the graft again because the graft's folded endo-in. So this is a demonstration what those look like. This looks like, of course, the endoglide, very similar to what you would use for DSEC surgery, but adapted for DMEK surgery. So here we see the forceps coming across the anterior chamber, reaching across to grab that DMEK graft, pulling it into the anterior chamber. Again, the irrigation is coming through the forceps. You could use an AC maintainer as well if you wanted, but in this case, since the flow is coming from those forceps, that flow helps to unfold that graft. Now, I'll show you this in action. This video is courtesy of Divya, who just gave this to me, who many of you know. So here's a case of hers, which she's using these forceps. This graft, again, is endo-in. So she's just holding on to it, and by either the assistant pushing on the plunger, or you can use surgeon-controlled foot pedal to control the irrigation, the graft unfolds spontaneously. Once it's unfolded, then you just sort of tap it to move it in position. So in this case, it doesn't matter how deep the chamber is. It's unfolding because of the fluid flow along the forceps. You don't need the iris plane to unfold the graft. So this technique is really helpful for these deep anterior chambers. So using this endo-in pull-through technique, the DMEK graft is folded by the surgeon or by the eye bank. Infusion, again, either controlled by an assistant or the surgeon. It's really helpful technique to transition for your trainees from DSEC to DMEK. Also avoids the need to shallow the anterior chamber to unfold the graft, and makes it possible to do DMEK in eyes with ACIOLs or sclerofixated PCIOLs. Thank you very much for your attention.
Thank you, Dr. Aldave, for a nice, giving us tips for a deep chamber. Opening the DMEK roll is so difficult most of the time. In the last video, your hole is, a single point hole in the DMEK roll. Will that flip sometimes inside the anterior chamber with the fluid on?
Shouldn't flip. I mean, if the fluid infusion is controlled, the graft should not flip upside down, for example. It may crumple up, but as long as you still have a hold on it, you should prevent it from being able to flip over. Just like with a DSAC graft, it should not flip over if you have a proper control of the graft, a hold of the graft.
Yeah, but terrific technique. It makes things life simpler if the graft opens up inside like that.
It doesn't work like that all the time, but when it does, it's awfully nice.
Yes. I think, we did cover the entire range of things which can be covered in our cornea session, right from the dry eye to infectious keratitis to keratoplasty and endothelial keratoplasty, difficult situations. I think we can take 5 more minutes here, though we are on time. Any question from the house? I think the speakers are here. They would definitely be happy to answer those questions. All of you are cornea surgeons, and you are from the Cornea Society here. Please, any questions? I see Dr. Kuris standing there. No, he always has a question. No, no. That's not the question.
One question I just asked is whether CorneaGen is the only company that offers this endo-in. Actually, there's other eye banks in the U.S. that do export internationally, like Lions in Tampa. They have a cannula that looks, has a flat portion where the graft resides. It's folded endo-in. In that case, you don't need forceps. You just push it in like you normally do. But the way the graft is folded, it tends to unfold spontaneously in the anterior chamber. It would also be useful for these deep anterior chambers. Yeah. So there's several eye banks in the U.S. that provide preloaded endo-in DMEK tissue.
Yeah, that's great. I think we would like to conclude. Thank you all the speakers for making this session so wonderful. I'd like to thank Jodh and Dr. Sujata for coordinating this, and to Hind and Dr. Rathi for making such a nice.
So now we will have a group photo.